Dear students, welcome to today's class Hereditary Haemolytic Anemia. Hemolytic anemia means anemia associated with bleeding. So, which is in turn associated with hereditary factors. So, hereditary hemolytic anemia usually results of intracorpuscular defects. So, that means in blood cells, blood corpuscles defects will be there. Then broadly classified as two groups: hereditary abnormalities of red cell membrane and hereditary disorder of interior of red cells. So red cell membrane damage will be there and interior of red cells. So this is how two groups of hereditary hemolytic anemia. First let us discuss about the hereditary abnormalities of red cell membrane. So these hereditary abnormalities of red cell membrane identified on blood film examination. So that means blood film we can examine and we can determine the red cell membrane damage. So this is three types: hereditary spherocytosis, hereditary elliptocytosis, hereditary stomatocytosis. So spherocytosis, elliptocytosis, stomatocytosis. So three types of hereditary abnormalities of red cell membrane. First, hereditary spherocytosis. So this is a common type and it is an autosomal dominant inheritance in which the red cell membrane is abnormal. So autosomal dominant inheritance. Then pathogenesis. So you should notice before pathogens autosomal dominant inheritance. So inheritance means associated meaning, dominant means dominant recessive factors. Autosomal, so allosomes means sex chromosomes, autosomes means somatic chromosomes. So it is a gene and chromosomes associated disease. Autosomal dominant inheritance. Pathogenesis, defect in proteins which anchor the lipid bilayer to the underlying cytoskeleton. So protein defect which are anchoring to the lipid bilayer of blood membrane. Next, that proteins names: spectrin deficiency, ankyrin deficiency. So spectrin one protein, ankyrin one protein. So spectrin deficiency, mutation in spectrin. So in case of spectrin deficiency, recessive inheritance is alpha spectrin, dominant inheritance is beta spectrin. In case of alpha spectrin associated hemolytic anemia, this one hereditary spherocytosis, more severe form of anemia will be seen, but 25% cases of patients will get alpha spectrin inheritance mutations, whereas beta spectrin mutations 75% of cases we can see patients. So it is called as a autosomal dominant inheritance beta spectrin mild form of anemia. But this one dominant form is more safe, whereas recessive form is more severe form of anemia will be seen. So first one is spectrin deficiency, second one is ankyrin protein deficiency. Of cases of hereditary spherocytosis, ankyrin deficiency will be observed. Ankyrin is a protein that binds protein 3 and spectrin. So protein 3 and spectrin is binded by the ankyrin protein. Homogeneous state with recessive inheritance severe anemia, heterogeneous state with dominant inheritance mild anemia. So ankyrin deficiency also, dominant inheritance is mild anemia is there, that means less anemia, whereas recessive is severe anemia. So recessive factors are both dangerous for the spectrin as well as ankyrin deficiency mutations. Then clinical features of hereditary spherocytosis: anemia, splenomegaly, jaundice, pigment gallstones. So these are the three clinical features observed in the patients. Treatment for this hereditary spherocytosis: splenectomy is only reliable. Spherocytosis, you can see here diagram: lipid bilayer and spectrin, alpha beta spectrin is there, then actin protein, ankyrin protein, then lipid bilayer band 3 glycoproteins, 4.2 4.1 proteins, and you can see normal red cell get converted into spherocytes which is engulfed by the spleen, splenic macrophage. So spherocytosis. Then continuation of hereditary spherocytosis, laboratory findings: anemia mild to moderate, reticulocytosis usually 5 to 20%, blood film abnormal erythrocytes in the form of microspirocytes. So shape of the blood film shows the erythrocytes RBCs microspirocytes in the microscopic observation. Then fourth one is MCV, normal or slightly decreased. MCHC is increased. Osmotic fragility test. So this is very important. Spheroidal RBCs lies more readily in solution of low salt concentration. In bracket we can see osmotic fragility is increased. That means due to the low salt concentration, the blood cells membrane will become smooth. So they become fragile. That means they can break easily. So low concentration of salt solution will break the RBCs. This is called osmotic fragility test. So the RBCs are placed in a low concentration salt solution, then these red cells will break easily. Next, autohemolysis. Osmotic fragility test after incubation and shows increased spontaneous autohemolysis, 10 to 15% red cells as compared to normal red cells less than 4%. That means in the normal red cells also we can see the hemolysis, that is autohemolysis, less than 4%, whereas in case of this hereditary spirocytes associated red blood cells will undergo more autohemolysis, that is 10 to 15% red cells. Then direct Coombs test, which is also called as an antiglobulin test, which will be negative for the hereditary spirocytosis, whereas are positive in acquired spirocytosis of AIH, autohemolytic anemia. Acquired spirocytosis will be observed. In that one it will be positive, whereas negative for the hereditary spirocytosis. Next, second type of this hereditary disease, red cell membrane, hereditary elliptocytosis, which is also called as a hereditary ovulocytosis. Autosomal dominant disorder involving red cell membrane protein spectrin. So spectrin protein is involved here. Blood film shows oval or elliptical red cells. So shape of the blood cells will be oval or elliptical. Clinically milder disorder than hereditary spirocytosis. So it is less dangerous than the hereditary spirocytosis. Elliptocytosis is less dangerous than spirocytosis. Inherited defect in erythrocyte membrane protein 4.1 that interconnects spectrin with actin in the cytoskeleton. So protein 4.1, which is connecting between the spectrin and actin in cytoskeleton, defect will be observed in the protein 4.1. Acquired causes of elliptocytosis include iron deficiency and myeloproliferative disorders. So iron deficiency, myeloproliferative disorders, we can see the elliptocytosis. Then third one, hereditary stomatocytosis. So here stomatocytes are cup-shaped RBCs having one surface concave and other surface as convex. So one surface concave, other surface convex. This causes a central slit-like or mouth-like appearance of red cells. Defect in membrane protein stromatin. So stromatin protein defect. Having autosomal dominant pattern of inheritance, the stomatocytes are swollen red cells, overhydrated red cells due to increased permeability to sodium and potassium. So here permeability is increased, sodium and potassium permeability. So liquid will move, water will move inside the red cells. So overhydrated red cells. The affected patients have mild anemia and splenomegaly. So patients will be mild anemia and splenomegaly symptoms. Then second group, hereditary disorders of red cell interior. So now we are moving to the hereditary disorders of red cell interiors. Till now we discussed about the red cell membrane, spirocytes, elliptocytosis, okay, stomatocytosis. Now red cell interior, two groups, enzymopathies, in meaning red cell enzyme defects, that means RBC enzyme defects is happening. So enzymopathies, hemoglobinopathies, disorder of hemoglobin. So hemoglobin disorder, enzyme disorder. So enzyme disorder again two, defects in the hexose monophosphate shunt, HMP shunt. So in the HMP shunt, enzyme glucose 6 phosphate dehydrogenase is involved, deficiency is observed. So G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency, that is one. Second one is Defects in the Embedden-Meyerhof pathway, which is also called as a glycolytic pathway. So defects in glycolytic pathway, that is pyruvate kinase PK deficiency. So pyruvate kinase enzyme will be involved. So PK deficiency is in case of glycolytic pathway deficiency. Defects, HMP shunt defects, glucose 6-phosphate dehydrogenase deficiency. These two coming under the enzymopathies. Whereas hemoglobinopathies, structurally abnormal hemoglobin, sickle cell anemia and hemoglobinopathies. Example for the structurally abnormal hemoglobin is sickle cell anemia and hemoglobinopathies. Second one is reduced globin chain synthesis, various types of thalassemias in which reduced globin chain synthesis will be observed. Now we will first enzymopathies, G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, comparing with the pyruvate kinase deficiency. Now glucose G6PD deficiency, among the defects in HMP shunt, the most common is G6PD deficiency. It affects millions of people through the world. G6PD deficiency gene is located on the X chromosome and affects males while the females are carriers. So this G6PD deficiency is mainly affected by the males, X chromosomal defect. Then females are carriers and asymptomatic. Normal G6PD variant is designated as type B white, type A variant black. That means white people, type B, type A black people. Then pathogenesis, normal healthy person, red cells are well protected against oxidant stress because of adequate generation of reduced glutathione via HMP shunt. That means through HMP shunt, glutathione synthesis will be more sufficient, which is protecting the red cells against the oxidative stress. Whereas in case of patients with inherited G6PD deficiency, enzyme deficiency, reduced glutathione in our red cells will be less. So glutathione is get reduced. The result in oxidation and precipitation of hemoglobin. So hemoglobin oxidation and precipitation happens with G6PD deficiency. Within the red cell forming Heinz bodies, H-E-I-N-Z, Heinz bodies. You can see here diagram Heinz bodies, dense bodies composed of precipitated hemoglobin. So one beside the hemoglobin one dot will be observed, that is precipitated hemoglobin. Then if you see PK deficiency, pyruvate kinase enzyme deficiency, is the only significant enzymopathy of the glycolysis pathway. This disorder inherited as an autosomal recessive pattern. So this PK deficiency comes under the autosomal recessive pattern. Heterozygote state is entirely asymptomatic. Homozygous individuals present during early childhood with anemia, jaundice and splenomegaly. So splenomegaly, anemia and jaundice for the homozygous individuals. Heterozygous state peoples no symptoms at all, so asymptomatic. Then laboratory findings, direct specific enzyme assay on red cells is the only diagnostic method. So directly enzyme we should identify PK enzyme, pyruvate kinase in the blood. Then clinical features of G6PD deficiency, acute hemolytic anemia, one. Second one is chronic hemolytic anemia. Number 3, neonatal jaundice, which is also called as a carnecterus. Acute hemolytic anemia, within hours of exposure to oxidative stress such as drugs like primaquine or infections, oxidation affects the older red cells only. So old red cells will get destroyed, whereas new red cells are not get destroyed. Hemoglobin levels may return to normal when the older population of red cells has been destroyed. So old red blood cells will get destroyed by oxidation, but newly formed red cells are not affected by the G6PD deficiency easily. Symptoms, hemoglobinuria and jaundice. So hemoglobin in urine and jaundice. Then second, chronic hemolytic anemia, severe enzyme deficiency have chronic persistent hemolysis throughout life. So throughout life persistent hemolysis will be seen. The second point, chronic hemolytic anemia, severe enzyme deficiency have chronic persistent hemolysis throughout life. Next, number 3, neonatal jaundice carnecterus, newborn infects with G6PD deficiency. So Here overall we can see clinical features of G6PD deficiency: acute hemolytic anemia, chronic hemolytic anemia, the neonatal jaundice, carnectaris for newborn infants. Then for this treatment, G6PD deficiency, prevention of hemolytic episodes such as stoppage of offending drugs. So here offending drugs, the drugs which are causing the disease G6PD deficiency, that drugs should be avoided. That is the major treatment. Hemoglobinopathies. So hemoglobinopathies, hemoglobin in RBCs may be abnormally synthesized due to inherited defects. So due to defects, RBC synthesis is not proper and hemoglobin synthesis is not proper. Two types hemoglobinopathies: qualitative disorder, quantitative disorder. Qualitative disorder, structurally abnormality in synthesis of hemoglobin. So here hemoglobin structure abnormality. Sickle cell syndrome and other hemoglobinopathies are the examples. Then quantitative disorder, quantitatively decreased globin chain synthesis of hemoglobin. So here globin chain synthesis will get decreased, which is the globin chain is present in the hemoglobin. So globin chain synthesis decreases in the quantity, that is thalassemia. Then both these groups of disorders may occur as homozygous state, heterozygous state. So homozygous state, both genes coding for character are abnormal. So homozygous state means two genes, both genes coding for character are abnormal. Heterozygous state, one gene abnormal and other gene will be normal. So abnormal and normal gene both will be there in the heterozygous state. Then double zygous, one parent will be HBS gene. That means hemoglobin, sickle hemoglobin. HBS means sickle celled hemoglobin. So HBS gene will be there. One parent will be having B-thal gene. So that means thalassemia gene. So one parent will be having thalassemia gene. Other parent will be having hemoglobin, sickle RBC causing hemoglobin gene. So both this sickle cell syndrome gene as well as thalassemia gene combinedly appearing in the child. So beta S and beta thal. So that is a double heterozygous state. Next, structural abnormal hemoglobins. So sickle syndromes, presence of sickle hemoglobins HBS in the red blood cells. The red cells with HBS develop sickling when they are exposed to low oxygen tension. So when oxygen supply to the RBC is less, they become sickling. Sickle syndrome are highest frequency in black race and in Central Africa. So sickle syndrome is appearing in the black race in America as well as Africa and Central Africa. Patients with sickle hemoglobin HBS are relatively protected against falciparum malaria. So they will get protection. That means the persons who are having sickle syndromes, they won't get the falciparum malaria. Sickle syndromes occur in three different states. One has heterozygous state, sickle cell trait AS, has homozygous state for HBS sickle cell anemia SS, as a double heterozygous state sickle beta thalassemia. So here you can see three states: sickle cell trait AS, sickle cell anemia SS, sickle beta thalassemia. So these three are the different states of sickle syndrome. In beta thalassemia, sickle C disease SC, sickle D disease SD. So these are the two types in the sickle beta thalassemia. Next, heterozygous state AS, that is sickle cell trait, homozygous state sickle cell anemia. So here we are comparing AS and SS. AS means sickle cell trait, SS means sickle cell anemia. So sickle cell trait, benign heterozygous state of HBS in which only one abnormal gene is inherited. So one abnormal gene will be there. Here sickle cell anemia, abnormal gene is inherited from each parent. So that means two abnormal genes will be there. Yes, in the SS sickle cell anemia. Here one abnormal gene is in sickle cell trait. And second, patients no significant clinical problems. So there is no clinical significant symptoms in the sickle cell trait. Whereas severe disorder associated with protein, clinical manifestations, and decreased life expectancy. So life, that means the age of the patient decreases and clinical manifestations will be there. That means clinical symptoms can appear. Then pathogenesis of this sickle cell anemia. First, basic molecular lesion in HbS substitution, that means sickle hemoglobin, valine for glutamic acid, that means replacement of valine to the glutamic acid at 6 residue position of beta globin chain. So in a beta globin chain, in a 6th position, valine is replaced in place of glutamic acid. So that means one substitution happens. So that is the basic mechanism happens in the sickle cell anemia. That is valine substituted to glutamic acid at 6th carbon in a beta globin chain. Second, mechanism of sickling. During deoxygenation, the RBCs change from biconcave disc shape to elongated crescent shape or sickle cell shape. So crescent shape, RBCs will get the crescent shape, then the biconcave disc shape. So you can see in the diagram here, normal blood cell, how it is there, biconcave, whereas sickle cell like half moon, that is sickle cell is looking like half moon. So diagram, crescent shape. Then reversible, irreversible sickling. So reversible as well as irreversible sickling may happen for the RBCs. Then factors determining rate of sickling. So rate of sickling, presence of non-hemoglobin S hemoglobins, HbS hemoglobins, intracellular concentration of HbS, total hemoglobin concentration, extent of deoxygenation, acidosis and dehydration, increased concentration of 2,3 BPG in the red cells. So this is how the factors, which are the factors affecting the sickling: oxidation, deoxygenation extent, acidosis and dehydration, hemoglobin concentration, and intracellular concentration of HbS. Next, clinical features of sickle cell anemia. So in sickle cell anemia, what happens? In this one, 3, anemia. Second point is vaso-occlusive phenomena. Third one is constitutional symptoms. So first one, anemia. So that means, as you know, decreased RBC hemoglobin, that is anemia. Second, vaso-occlusive phenomena, that means obstruction in capillary blood flow. Vaso-obstruction results in infarcts. Two types of infarcts: micro-infarcts, macro-infarcts. Micro-infarcts, abdomen, chest, back and joints. So it will be observed. And macro-infarcts in the spleen, bone marrow, bones, lungs, kidneys, central nervous system, retina, skin. So macro-infarcts in spleen is causing splenic sequestration, autosplenectomy. In bone marrow, it causes pain. In bones, aseptic necrosis and osteomyelitis. Lungs, pulmonary infections. Kidneys, renal cortical necrosis. Central nervous system, stroke. Retina, it will cause damage of retina. Skin, ulcers. So this is all these vaso-occlusive phenomena, infarcts, due to obstruction in the blood flow in the capillaries. Then third, constitutional symptoms: increased susceptibility to infection, impaired splenic function. So spleen function get impaired. Next, other structural hemoglobinopathies. Hemoglobinopathy is having 4 categories: HbC hemoglobinopathy, HbD hemoglobinopathy, HbE hemoglobinopathy, unstable hemoglobinopathy. So here HbC, DE and unstable hemoglobin. So which area these hemoglobinopathies will be observed? Prevalent area and genetic changes. So first one, you see HbC hemoglobinopathy, West African American blacks. What happens? Genetic changes: substitution of lysine for glutamic acid at beta 6 globin chain position. So lysine for glutamic acid at beta 6 globin chain position. D, hemoglobinopathy, Northwest India, Pakistan, Iran. So Northwest India, that means Gujarat, Rajasthan, Northwest India, Pakistan and Iran. Substitution of glutamine for glutamic acid at beta 121 globin chain position. So then E. Hemoglobinopathy, Southeast Asia and India, Burma, Sri Lanka. Substitution of lysine for glutamic acid at beta 26 globin chain position. Then unstable hemoglobinopathy, it is prevalent area is not proper. Then genetic changes is single amino acid substitution in globin chain. And here hemoglobin denaturation and precipitation within the red cells has Heinz bodies, Heinz bodies. So here genetic changes you should notice in all the CDE hemoglobinopathy, glutamic acid position is common. So glutamic acid position is replaced by the first C is lysine, number 6 position, and D glutamine replacing glutamic acid 21 position, then E is lysine replacement in the 26th position. So here glutamic acid replacement with the lysine, glutamine and lysine again happenings. Then okay, diseases, deletion of 4 alpha chains, total suppression of alpha globin chain synthesis. HB Buds is a gamma globin chain tetramer which has high affinity, leads to severe tissue hypoxia. Clinical features of this hydropis foetalis, severe tissue hypoxia, infant dies shortly after birth, fatal in utero. If born alive, the features of severe RB hemolytic disease are present. So even if the baby is born, it should die. If it is not died, it will be suffering with the hemolytic disease. Then HBH disease, deletion of 3 alpha chain genes precipitated as Heinz bodies within the affected red cells, termed as HB constant spring. Well compensated hemolytic anemia, splenomegaly may develop cholestasis. Then important here, beta thalassemia, which is the major in India. Decreased rate of beta chain synthesis resulting in reduced formation of HBA in the red cells. So beta chain synthesis is decreased. In that one, beta 0, beta plus. So beta 0 indicates complete absence of beta globin chain synthesis. So here beta globin chain synthesis completely absent. That is beta 0. Beta plus indicates partial synthesis of beta globin chain. So small amount of or partial synthesis of beta globin chain is beta plus. Beta 0 means absence of complete beta chain synthesis. So beta 0, beta plus. Some effects on beta globin chain synthesis: transcription defect, translation defect, mRNA splicing defect. So these 3 defects will be there in the beta globin chain synthesis. Depending upon the extent of reduction in beta chain synthesis, 3 types of thalassemia. Beta thalassemia again 3 types. Homozygous form, beta thalassemia intermedia, heterozygous form. So here homozygous form, heterozygous form and beta thalassemia intermedia. First one, homozygous form is called as a beta thalassemia major. So this is a very important. Most severe form of congenital hemolytic anemia comes under the beta thalassemia major. It is further divided into 2 types. Beta 0 thalassemia major, characterized by complete absence of beta chain synthesis. Beta plus thalassemia major, incomplete beta chain synthesis. So here again beta 0 thalassemia major, beta plus thalassemia major. Then beta thalassemia intermedia, intermediate degree of severity, does not require regular blood transfusion. These cases may be genetically heterozygous, beta plus or beta 0. Heterozygous form, beta thalassemia minor. So heterozygous form is beta thalassemia minor, it is a trait. Mild asymptomatic conditions, moderate suppression of beta chain synthesis. So here important is it is a homozygous, heterozygous and the beta thalassemia intermedia. So beta thalassemia major is very important. Next, major clinical features of beta thalassemia major. So we are going specifically beta thalassemia major. Symptoms: pituitary gland stunted growth, expanded bones, malocclusion jaw, splenomegaly, cardiac siderosis, liver, in the liver hemosiderosis, pancreas diabetes mellitus, increased iron absorption. So these are all the clinical features observed in the patient of beta thalassemia major. Then principles of treatment for beta thalassemia major: 7 points. First point, anemia is generally severe and patients require regular blood transfusions 4 to 6 weeks. So 4 to 6 weeks, that means 1 to 1.5 month, they should blood transfusion should be done to maintain hemoglobin above 8 gram per deciliter. Next, second point, in order to maintain increased demand of hyperplastic marrow, folic acid supplement should be given. So folic acid supplement should be given. Third point, splenectomy is beneficial in children over 6 years of age. So splenectomy is preferred for the children's. Fourth point, prevention and treatment of iron overload is done by chelation therapy. That means they are going to avoid the excess of iron in the blood by the treatment with chelating agents, iron chelating agents, desferrioxamine and deferoprone. So these are the iron chelating agents used to remove the excess iron from the blood. Then fifth one, bone marrow transplantation from HLA matched donor that provides stem cells. So bone marrow transplantation of the patient who is having HLA gene, all patients will be having HLA gene, but HLA gene should match so that we can provide the blood bone marrow we can supply and stem cells we can supply. Which can form normal hemoglobin is being done in many centers with firm success rate. So that they have done with the success bone marrow transplantation. Sixth point, some workers have found success with cord blood transfusion. So spinal cord blood transfusion they have done and they have got success. The seventh one, gene therapy of thalassemia involving genetic manipulations in hematopoietic stem cells may become future option. So gene therapy for the thalassemia is the major option for the future researchers. Thank you. Refer Textbook of Pathology by Harsh Mohan, 7th edition. Thank you.